welcome all speakers and a couple of members of the audience. We start with the breakfast session of the Cornea Society of India, which is devoted to basics. Nikhil is not here. Can I invite Dr. Paras Mehta to tell us about acute chemical and thermal injury as first speaker? Welcome, Namrata, and congratulations. Hi. Yeah. Bhaskar is not here. You're reading for him? Okay. Shreyas is here. Vinay is not here. Okay. To the speakers only. Paras, she's speaking for Bhaskar. But she's in town.
Is this opening Shweta's?
Hi, Himanshu. Come.
Not this.
Come join us.
The other one. The first one.
I think so.
Yeah, that's fine. Good morning, everyone. Good morning, everybody. At the outset, I would like to thank the organizers of AIOC and thank you for, including me for this CSI session. Today, I would be talking about acute chemical injuries. As we look at these cases, we would be reminded of how promptly we have to act on these cases. They would present in different grades and different formats. When I talk about this, I would like to say that ocular surface reconstruction begins from an acute stage management. So revising the concepts of emergency management and appropriate timing of the intervention can make major difference in the final outcome. The aim here would be to achieve these kind of outcomes rather than the previous slide, as you can see here, the previous picture. If you achieve this, probably the vision restoration is possible with surface reconstruction in the later part in a much better manner. Chemical injuries almost comprise of 7.1 to 11.2% of the total eye injuries, and 15 to 20% of the burns of the face involve at least one eye of these patients. It's a true emergency. The first few minutes of the on-site management can make a major difference in the outcome significantly. Later, a primary care doctor can play a big role in the management and ultimate outcome. By the time the patient presents to an ophthalmologist, it is relatively late. So it should be an emergency management on-site. A prompt initiation of an appropriate management is very crucial for these cases, and timely referral to a cornea specialist is also important. The challenges we face with these cases are many. Many a times we face we don't know what are the compounds or the chemical agents to which the patient is exposed to. There could be delayed presentation to the ophthalmologist. The chemical compounds could be household cleaning or bleaching agents, holy colors, various chemicals, liquids, fumes, vapors in the industrial setup. It could be mixed compounds in different concentrations. Sometimes it could be cement powder, or there could be associated thermal injury. The children, if they are affected, may require an examination under anesthesia, and commonest and worst injury is a Lyme paste injury in Indian scenario. The overall outcome would depend on the type and concentration of the chemical, the contact period with the tissue, the extent of the tissue damage, compliance to the therapy, and laterality of the injury. It's also known that, the ocular alkali burns would be more severe if it is an intentional injury rather than an accidental injury. The time to reepithelialization would depend on the degree of the grading of the burns. It may take about 1 week to 10 days for grade 1, or it might take longer than that for grade 3 and grade 4 cases. It could be few weeks to few months for grade 3 and grade 4 cases. Similarly, the visual outcome would also be worse in the grade 3 and grade 4 cases, while it would be better in grade 1 and grade 2 cases. Various classifications have been proposed. One of them was most popular, proposed by Roper Hall and group, wherein they considered chemical injuries into 4 groups. First 2 groups having a good prognosis, they considered corneal findings and conjunctival findings, and the grade 3 and grade 4 had the guarded and poor outcomes. But there were certain limitations to this classification. There was like, like if you look at that, how does corneal haze at onset would influence the final visual outcome? Many a times the corneal haze may be more on the day 1, on the presentation of day 1, and it may be less on day 2 or later down the line. So again, this was a limitation. Similarly, the conjunctival findings. The another area here would be how would you identify the ischemia at the slit lamp? So there was no way of quantifying that. Would a 51% limbal ischemia have the same prognosis as the 100% ischemia? Because there was no discretion between these 2 groups. So based on that classification, if you look at this clinical picture, this particular clinical picture would fall into hazy cornea, but iris details are visible, so it would fall into both the groups, grade 2 as well as grade 4. So these were the limitations, and that's why another classification was proposed by Professor Dua and group, where they divided that into further 3 groups, like 1, 2, and 3 having very good to good prognosis, while grade 4, 5, and 6 were having good to guarded prognosis, or grade 6 would have very poor prognosis. Here they considered the clinical findings in terms of limbal involvement, the conjunctival involvement, and both of them were converted into analog scale. So that turns out to be much relatively useful classification at the moment. If you look at this example of chemical injury here, you can see that almost more than 180 degree of cornea is involved with limbal ischemia. There is a lot of corneal haze, and significant amount of conjunctiva is also involved. So probably it would fall into grade 4 to 5 of chemical injury according to Professor Dua's classification. So before beginning for the management, one would like to have a first impression on the initial examination. It's important to re-examine these patients at every visit and reassess the level of injury to the ocular surface and the surrounding areas. As I said earlier also, the classifications so far have limitations, hence we need to have a dynamic classification, or at times you have to reassess these patients on second day or at 1 week and regrade them, whether they are falling into grade 1 or they are falling into grade 2 or which grade. Based on that, the overall prognosis can be decided. The primary management would include the patient must receive adequate wash for sufficient time. This could be best on site in terms of sprinklers and showers at the industrial setup. The patient should be rushed to nearby ophthalmologist or a primary care person, and promptly the steroid should be started, and a repeat thorough wash till the pH is neutralized. Removal of the particulate matter if it is present, and examination with double immersion is mandatory. If the patient is a child, maybe probably examination under general anesthesia would help a lot. Thorough cleaning of the fornix is recommended, and assess the situation well, and it is important to document the level of injury as well. The goals of primary management would be control of inflammation, that is most important, to promote epithelialization as early as possible, supplement vitamins, control intraocular pressure, and prevent secondary infection, and in turn minimize fibrosis and scarring and prevent complications. One would like to start topical steroids if there are no signs of infection, topical preservative-free lubricants to promote epithelialization, broad-spectrum antibiotic in maintenance dosage, anti-glaucoma medication based on the IOP levels, systemic anti-inflammatories, and maybe vitamin C in terms of systemic vitamin C, and topical ascorbic acid eye drops, which are prepared fresh and instilled every hourly or 2 hourly. Improve the overall nutrition of the patient. Look for any further management changes as per the need of the patient. This is sufficient enough for grade 1 and grade 2 cases. For severe cases, one would require, do I have a minute or so? Yeah. For grade cases more than grade 3 and 4, one would resort to use of surgical intervention in terms of using amniotic membrane grafts to promote epithelialization. One can do tenonplasty or tarsography. And recently, a group from SN has promoted allogenic limbal stem cell transplantation for faster epithelialization in very severe burns. And one can even combine these approaches in these cases. It's preferable to do an amniotic membrane transplantation in less than a week so that you have better results. One can adjust the dosage of steroids based on how the patient is behaving. If the epithelium is not healing in 7 to 10 days or 14 days, one would like to cut down on the steroids and resort to other modalities of management. And one should also look for timing for other interventions. The amniotic membrane would help in decreasing the inflammation. It would help in facilitating the epithelial healing, reduce scarring, and decrease vascularization. These are just the clinical examples. This is a very mild, or I would say grade 1, grade 2 injury with Lyme cluster. So these cases can be treated with just the medical management. This is another example of acid injury, falling into grade 2 to 3. And because there was total epithelial defect with involvement of the conjunctiva, we resorted to amniotic membrane, and he ultimately recovered very well. As you can see here, with little amount of limbal stem cell scarring and limbal stem cell deficiency, and overall the central area is looking much better. This is another example having grade 2 to 3 injury in right eye and grade 2 injury in the left eye. This is an example of alkali injury where the right eye is affected more than the left eye. The patient had almost grade 4 injury in the right eye and grade 1 injury in the left eye. He underwent 2 sittings of amniotic membrane with medical management, and as you can see here, the overall outcome is much better. This is an example of grade 4 to 5 injury, severe acid injury with disulfuric acid. Clinically, there is 360 degree link. Yeah, sure. I will just go on. So to summarize, it is important to attack the inflammation first. The aim is to achieve surface stabilization as early as possible. Use adjunctive procedures to facilitate surface healing and minimize the scarring. In later, more definitive procedures can be offered for visual rehabilitation for these cases. We need to orient ourselves to manage for the management of these acute injuries. The aim is to achieve stable ocular surface as early as possible so that these patients can be taken for vision restoration later on. Thank you very much for the kind attention.
Thank you, Dr. Paras, for a very comprehensive review of emergency management of acute injuries. Can I invite Dr. Shweta to talk about current options in ocular surface reconstruction? She is speaking on behalf of Bhaskar. Couldn't be here. Thanks, Shweta.
A very good morning. I'll be talking about the current options in ocular surface reconstruction. So ocular surface disorders is a very broad term which includes anything which affects your lids, conjunctiva, cornea, and the tear film. A careful assessment of the big four will help determine the appropriate therapy for these disorders. Well, you have to have a stepwise approach in dealing with patients with ocular surface disorders, and today's talk will focus around the surgical procedures. Let's go through a few case scenarios to understand this a little better. A child with golden hour syndrome presents to us with a large lipodermoid. Few things, the main indication being a significant refractive error, or 2, the parents are extremely keen for cosmesis. Intraoperatively, only the part which is visible in the palpebral fissure is the part which needs to be excised. Careful handling of the conjunctiva and tenons, and try and retain as much as of normal conjunctiva as possible to reduce the postoperative scarring and facilitate better epithelialization in the immediate postoperative period. Before excising, it would be advisable to go ahead with cauterization of the edges to decrease the intraoperative bleeding. The bare area is covered with an amniotic membrane, and then the retained normal conjunctiva is secured back with fibrin glue, and a BCL is placed. 4 months later, the child with no recurrence, good cosmesis, moist eyes, and a stable tear film. Another patient who presented to us with a grade 3 symblepharon following a chemical injury had already undergone a symblepharon release with conjunctival limbal autograft and mucous membrane graft done elsewhere. You see a significant hypertrophied mucous membrane graft. The patient underwent a symblepharon release with an amniotic membrane on the bare surface and conjunctival autograft just in the perilimbal area. A month later, the fornix is well formed, the surface is stable, and the vision is 6/6. Now, the patient with a grade 4 symblepharon underwent a symblepharon release, this time with a mucous membrane graft on the lid margin and an amniotic membrane on the surface, post which the surface is epithelialized, fornix is well formed, and vision is 6/6. So, well, what decides the surgical technique for symblepharon is the basic grading of symblepharon. So, the vertical height of the symblepharon will decide whether you need an anchoring suture. The horizontal width of the symblepharon will decide whether you can get away with an amniotic or an amniotic with anchoring sutures, conjunctival autograft, or a mucous membrane graft. So, if it's only the bulbar surface, which is raw post-symblepharon release, an amniotic membrane would suffice. But if you have a bare area which involves the bulbar and the fornicial conjunctival areas, then an amniotic with a conjunctival autograft would be a better option. The inflammation in the symblepharon will decide whether you will need intraoperative mitomycin C also. Well, is there a way that you can provide these chronic sequelae of chemical injury? Probably a better and a faster management in the acute stages, as well described by Dr. Paras. Well, in the earlier times when patient presented to us with these grade 4 and above chemical injuries, we would go ahead with multiple amniotics and tarsorrhaphy. The surface would finally get epithelialized in 4 to 5 months with a scarred vascularized cornea and symblepharon. We tried using a flexi-symblepharon ring using an IV tubing to keep the fornices better formed. It did result in better fornices, but it still took a lot of time for the surface to epithelialize, which is when this question came forth. Is amniotic membrane sufficient enough in patients with grade 4 and above chemical injuries, or do we need to provide an external source of epithelium for the surface to epithelialize faster? Which is what we tried in this child, which was a child with grade 5 chemical injury. Post multiple amniotics, the surface was still bare. We went ahead with a cultured oral mucosal epithelial transplant. A month later, the surface did epithelialize. 2 months later, the child came to us like this with a total symblepharon and then started the surface reconstructive procedures. We went ahead with a symblepharon release with mucous membrane graft to the lid margins and an amniotic membrane to the bare surface. A month later, the fornices were better formed, but still, as you see, there was a small patchy area of keratinization because of the exposure, because the patient still had some amount of lag of thalamus and entropion. We went ahead this time with a superior symblepharon release again, this time with a conjunctival autograft also on the bulbar surface. Resulted in a well-formed fornix, while the eyes closing well and a good blink. If you see, this patch of keratinization, which was earlier there on the cornea, has now reduced with a good blink and the eyes being moist. Now the child has underwent an autoslet and we are waiting a glass appointment for her. So a child who presented to us with a grade 4, after management in the acute stage, presented with a total symblepharon, underwent multiple surface reconstructive procedures, is still going the same and is still awaiting visual rehabilitation. Which is when we realized that losing these 2 weeks in the acute stage, which is required for the cells to grow in the lab, is probably too much and we need something more faster. Well, which is when we came forth with this idea of AIOC2017. It is based on the same concept as autoslet, but since using an autologous limbal tissue in the acute stages is usually not recommended, we went ahead and harvested limbal tissue from the cadaveric donor cornea. The rest of the technique is very similar to what we do in autoslet. So a patient who presented to us with a grade 5 of chemical injury, Dua's classification, underwent an AIOC2017. A month later, the surface was completely epithelialized with a corneal phenotype and vision of 6/9 at 1 month. Another child who presented to us with a retained Lyme plaque and a total defect underwent a plaque removal and an AIOC2017. A month later, the surface is epithelialized and the child had a vision of 6/12. 4 months later, we do see a partial limbal stem cell deficiency over here, following which the child underwent an autoslet and now, a year later, maintains a vision of 6/9. There are multiple advantages of AIOC2017. It being an allogenic source of epithelium, you can harvest the whole limbus. It's a single-stage procedure, no lab required, facilitates faster epithelialization, corneal clarity, faster visual recovery, and therefore reduces the chances of amblyopia in these children. The mean time to epithelialization was noted to be around 5 months in our earlier experience, where we would only use an amniotic membrane transplant, which has now reduced to 22 days with the use of AIOC2017. AIOC2017 has also a role in chronic bilateral limbal stem cell deficiencies, as was done in this patient with a lid margin disease. Underwent an AIOC2017 and now 20 months later with on-tablet isothioprin maintains a vision of 6/9. To summarize, ocular surface reconstructive procedure is like growing a plant. So you have to have a stepwise approach. The main aim in the acute stage is to facilitate faster epithelialization. Chronic stage is all about restoring anatomic and physiological ocular surface. Tear or the lacrimal status is one of the most important prognostic factors in ocular surface reconstruction. Thank you.
Thank you, Dr. Shweta. And I invite Dr. Somashila to talk about current techniques of keratoplasty.
Good morning. Okay, that's too loud. So I thought that the people who attend this session will be those who are really, truly, madly in love with cornea. And that's the people who are here. And it is kind of redundant to talk about just an update on current corneal transplantation techniques. So I thought I'll take you to the future as well and what's coming up. So this is needless to say that even latest data show that there are so many millions of people blind due to corneal scarring, though we kind of underrate it in terms of the global statistics for one of the causes of global blindness, but we know very well how debilitating it can be. And of course, it's frustrating that very often, many of the causes of corneal blindness are needless and could have been prevented. And we just are left with no therapy for that. So it's a rather poor show in our efforts to combat what I would rate as the fourth leading cause of blindness or needless blindness in the world. So it follows the more glamorous causes, I would say, of blindness, cataract, glaucoma, and AMD. Why I sound upset is because there isn't enough policy, advocacy, or money in treating corneal diseases, which there should be, because we have now more and more treatment coming up which can help these patients. So corneal transplants alone will not suffice. We don't have enough tissue, we don't have enough surgeons, and technically it's challenging. And the post-operative, depends on so many other factors, including patient follow-up and medication. So why are we still talking about tissue or component of cornea transplants? So what's hot off the press is that we have multiple studies talking about mesenchymal in vitro proliferated stem cells for stromal scars and endothelial cell cultures, as well as collagen scaffolds. So you have components of the stroma, the endothelial cell transplant for endothelial diseases, and collagen scaffolds. Obviously, you already have the component for the epithelium, which is so successful with SLET. So that is already in, and as the previous speaker pointed out, is pretty successful. So just for those of us who, in order to be, I didn't want to get scolded for not completing what I'm supposed to complete. So I'm also talking a little bit about keratoplasty, which is full or partial thickness corneal tissue replacement, which can be anterior lamellar or posterior lamellar. And we know the entire list that anterior lamellar includes all the way from anterior to deep anterior, depending on where you want to split hairs or split the collagen. And the posterior lamellar includes DLEK, DSEK, as well as DMEK. So I'll not go through this. Just to highlight for any of us who would like to be reminded that we used to start off with the superficial anterior lamellar keratoplasty, which we used to use the microkeratome. Now many of us do use the femtosecond assisted anterior lamellar keratoplasty. It makes it very simple and elegant because you have both the planes which are very equal and stable rather than using a microkeratome or any other way of doing a superficial lamellar keratoplasty. So we can have the automated one, which many of us used to use a lot earlier. Most of us now use a technique which is either pre-decimetic or it's a big bubble or a desmase exposed kind of technique, which is the traditional DALC, and I don't think I'll show any video of that. So in endothelial keratoplasties, what we currently have is many variations of DSEK. We have DMEK, we have PDEK, and so on. Whichever technique we resort to, the indications are slightly different, but we can achieve beautiful results with our PKs. We can achieve excellent results with DALC, with DSEK, and of course with DMEK, which is technically challenging, but I'm pretty sure that more and more people will convert to DMEK. Currently, the statistics show, even in our own hands, is that we have about 50% still of optical or of penetrating keratoplasties. About 50%, very close to 40% would be the endothelial keratoplasties, but they're catching up. And the rest of them include DALC and DMEK. So that's about 10%. So what I'm actually focusing on is the adjunctive procedures, which includes SLET, limbal stem cell transplantation, which was, earlier we used to use cultivated. There's so many other adjunctive procedures, which includes placing AMG as a donut shape around the limbal area in those cases where you're doing a regraft, for example. So this sort of replenishes or refreshes the limbal stem cell niche and helps the limbal stem cells to regrow well. So this is a patient who has SLET on the surface, and this is another patient, a chemical injury, who initially has an amniotic membrane. So as you already pointed out in the previous talk, Shrita, was about the beautiful results of SLET. This is a patient with acute chemical injury. This is after amniotic membrane transplant, waited for the acute phase. Patient comes back with corneal vascularization. Earlier, we might have resorted to doing some kind of maybe PK with or limbal stem cell transplants, the cultivated ones. But this patient underwent SLET, so this is the result a few months later. This is a year later. This is 2014, and this is 2015. This is very recent, till the last follow-up in 2016. The child it's a young patient achieving 20/40 vision, from all the way from a vascularized surface to a nearly very excellent transparent-looking cornea. So coming to the thought process from SLET, so it looks like the limbal stem cells are even replenishing the stromal surface. So Sayan Basu, who works with Dr. Sangwa, and both of them are involved in this work, looked at the stromal stem cells, which he could isolate when he was doing his fellowship, from the limbal biopsy tissue. And they studied it in the mice, and they actually saw that the stem cells that derive, they also proliferate into mesenchymal stem cells, which actually help in replenishing stromal scars. So can mesenchymal stem cells help in restoring corneal transparency? According to these authors, with this recently published paper from one of the groups that we're in collaboration with, actually has shown excellent results. Of course, not in humans, but in not in cadaveric, but in mouse models. So imagine the clinical situation that we could have it in. We could use mesenchymal stem cells to take care of the opacification that we know will happen after corneal ulcer. We could use it in chemical injury. We could use it in persistent epithelial defect. And we could use it in a bugbear, that is post-PRK stromal haze that we see. And we can also use it to clear the corneal scar tissue. It sounds amazing and it sounds impossible. But we have initial results from science group, and they're already recruiting patients. It's been approved by our IRB, where they're using a stromal-derived stem cell, mesenchymal-derived stem cells for the stroma to clear scars. Not of this opacification, but he has his results, which I'm not at liberty to share. And other cases, even advanced Murren's ulcer, and other cases such as very bad limbal keratoconjunctivitis and Stevens-Johnson syndrome. So that was about mesenchymal stromal stem cells. So imagine you have a situation where you don't need to do ALK or FALK or DALK because you have stromal cell cultures. You inject it into create an epithelial defect, inject it, or just apply it sort of like a paste with fibrin glue and paste a PCL on top. And over a period of time, the stromal scar remodulates and you can have a near clear cornea. And we have seen this. We have 4 patients recruited in this study. So coming to the other end of the cornea, which is the endothelium. So what are the approaches for transplantation for corneal endothelium? We can either derive corneal endothelial cells by growing it. The earlier concept used to be that you can't grow endothelial stem cells, they're end-stage cells. But that seems to be not true. And luckily, these cells do have some pluripotent or mitotic capacity. And the more younger the cornea, for example, neonatal corneas or pediatric corneas, the more likely we can get cells from these. And the second part would be, how do you deliver these cells? Do you do direct injection, like the groups have already published, or do you do a monolayer? So you can have a carrier, which could be collagen, or which could be, what we are also looking at is a silk-derived carrier, or various other polymers, and place the cells on that, and that is slid into the eye and stuck onto the descemes membrane, just like how we stick a DM graft, or just like how we stick a lenticule in EK. So this is the other way of delivering the cells. And or you can make a pocket in the posterior-most part of the stroma. And it's really interesting that you can put the cells either on the top surface of the scaffold or on the bottom of it. So you can put it, depending on which side you've put it, that's how you can place it. So this is just some results, just another 30 seconds more of the explants, endothelial cell cultures. This is a 5-day-old corneal tissue of a donor who's 5 days old, 16-year-old. You can notice that the older tissues don't grow that well, so you really need very young donors. And I'll skip this just to talk to you about this patient where we've gone ahead and we've have approval for a pilot study. So this is a 63-year-old who had post-corneal cataract surgery developed pseudophakic bullous keratopathy. And this is after endothelial cell injection into the anterior chamber. This is 1 week. Doesn't look so great, but at post-op 1 month, there is a little bit of clearing. So this is a very recent case. The patient is yet to complete 3 months and then 6 months. So we do not claim that it works yet, but this is something interesting that is there for the future. So looks like we need to move slowly away from actual tissue because of its scarcity. But imagine that if you have a tissue, you can culture its endothelium, you can use its stroma, and you can just do amazing things with it in order for the same tissue to be available to many patients. So that's all I had for my talk. Thank you.
Thank you, Dr. Somashila. It would turn our traditional thinking on its head if we do succeed in transplanting endothelium and letting it grow. I invite Dr. Shreyas Ramamurthy to tell us about newer diagnostic devices in corneal and refractive surgery.
I thank the organizers and CSI for having included me in this course, and it's an honor to follow such stalwarts in the field. So today I'll be talking to you all on newer investigations in cornea and refractive surgery, and it would be almost impossible for me to cover the entire gamut of investigations that we have available with us today, which has really revolutionized our practice. But I'll stick to a few investigations which has really made a lasting impact and whose potential is yet to be completely realized. One of the newer or probably not as new now, but something which is still evolving and newer adaptations are being formed is in the field of ASOCT, which has had a great impact, not right from the beginning of diagnosis or preoperative planning, as now the intraop ASOCT and also in post-op evaluation. I'll start off with a case where on day 1 you had this diffuse corneal edema, so in a hard cataract, whether this was just striate keratopathy or whether this is a form of a limited TAS, or do you have a decimus membrane detachment. Slit lamp microscopy is inconclusive. A Scheimpflug image doesn't add much to your information either, but an ASOCT clearly shows a shallow decimus membrane detachment which was not obvious on a slit lamp examination. So it has far-reaching consequences, where even in a preoperative planning, on a slit lamp microscopy, it's hard to tell whether this, what is the exact depth of involvement of this granular dystrophy, whether you'll be able to get away with an ALK or a DLK. But an AIOC clearly tells you the density of the deposits in the posterior stroma as well, and you would be better off going in for a DLK in this patient. Also in the case of a corneal scar, with the advent of DALK and its obvious advantages, it really tells us helps us assess the depth of the scar and whether we need to go ahead with a DALK or a PK in such cases. Intraop ASOCT still remains an expensive tool, is still sparsely used, but has great potential when we are moving on to lamellar transplantation. This is a picture of an intraop ASOCT in a DMEC roll, which really tells you which way is up, where you can see the folded decimus side, which tells you you're on the right side and is of great assistance, and also tells you whether it has been attached properly or whether you still have some interface fluid. Another application is, of course, in DALK, where when you're trying to get your big bubble, you want your needle as close to the posterior stroma as possible. And in these difficult cases of advanced keratoconus, it could be of great advantage. In the postoperative period, of course, it helps us assess what is your graft-host junction, what is the resolution when you're doing lamellar transplantation. You can see in DALK there's absolutely no interface visible, whereas in this ALK with a clearly visible interface, and how smooth the interface is. In DSEC and DMEC, it can help you in telling you what is the graft adherence, can help you measure the thickness of the graft which you have put in, and whether you need to do rebubbling procedures in such patients. Moving on to refractive surgery, we can help measure the depth of the intracorneal ring segments, how deep we place it. We all know that it needs to be at least 70 to 80% depth for you to have a good effect of the intacs. In C3R, it really has helped us to compare the various protocols, looking at the depth of demarcation line, which serves as a surrogate measure for the extent of cross-linking and looking at its depth. Extremely important application is in the use of ICL, where in preoperative assessment it can help you to measure the white to white or the sulcus to sulcus diameter, and then in postoperatively to look at low or high vaults. And even when you have a patient with high vault, even though on slit lamp you can only say it's a high vault, ASOCT really helps you to measure the angle opening and can help us predict whether this patient would be at risk of raised IOP and angle closure in the future. Again, in LASIK, it really helps you in measuring the flap thickness, about looking at your residual bed. Now, this is something which we never had before when we were planning enhancement procedures. Now, how thick is your flap? How much ablation you can do on top of the flap? And actually accurately measuring the residual bed thickness, especially when the case has been performed elsewhere. A newer application of ASOCT which has come in is the epithelial thickness map, which again has far-reaching implications when we are doing refractive surgery. Now, again, the epithelial thickness profiles have been measured, and in post-LASIK eyes, it has been shown that there are a large amount of changes which take place over a period of time and is directly correlated with the extent of depth of myopic ablation which we perform. So as we all know, compensatory epithelial hyperplasia is one of the causes for myopic regression, and it can easily be measured in serial maps as you see an increase in thickness, and this could probably be the result of epithelial regression, and you could address the enhancement appropriately. Again, we all know that the epithelial thickness profile in keratoconic eyes clearly shows that the thinnest epithelium is over the apex of the cone and tends to be broader over the base of the cone. An example here of an epithelial thickness map, as you can see, over the apex of the cone here, it tends to be much thinner, and these could be early indicators for differentiating from keratoconus from normal eyes. Differentiating keratoconus from normal eyes, however, nowadays is really not that much of a challenge. But when we are including patients for refractive surgery, it really is form thrust keratoconus versus normals. And another useful application which needs to be fully explored is the Bowman layer thickness mapping using ultra-high resolution ASOCT. As we all know, Bowman layer is one of the first layers to undergo disintegration in keratoconus, where even when the stroma is only minimally affected. So this is something which we can look forward to in the future. Scheimpflug devices have been around for some time now, and we have multiple parameters, numerous numbers. We have the overall D of Pentacam. We have the newer dual Scheimpflug images like Galilee. But unfortunately, even today, the highest sensitivity that we have using the Kramer-RC index is only about 93% to differentiate between normal and form thrust keratoconus. We really need to do better when we are choosing these borderline cases for refractive surgery. Corneal biomechanics, however, is still in its infancy, and devices like the ORA and Corvus, which help study the biomechanics based on the deformation on air puff, even though they do help differentiate normals and keratoconus, they have poor sensitivity when it comes to subclinical keratoconus and normals. A new index has been developed in Corvus, taking into a number of individual parameters called the Corvus Biomechanical Index. And I'll just show you a quick case example where absolutely normal pentacam pictures, the overall D is absolutely white, but then the CBI shows a red factor. And if you look at the fellow eye, it has proper advanced keratoconus. So these are a number of eyes which are really not being detected by the standard Scheimpflug imaging which we have today. So a marriage of these two techniques would definitely be worthwhile. And this is probably the step ahead where we have a combination of various indices available with us today, combining the Corvus and the Scheimpflug imaging, and one of them being the tomographic biomechanical index, which is a combination of both, where you see a Corvus biomechanical index here, giving you a good sensitivity, overall D from bad, which is a slightly higher than the CBI, but then when you can combine the two, the index, the sensitivity and the specificity increases markedly. And as you can see here, a fellow eye of a keratoconic patient, which otherwise in Scheimpflug was absolutely normal, giving you a red flag sign on the TBI. Moving forward, one of the newest applications which we have, Brillion microscopy, which is yet to be adapted widely and is still very much in its prototype, can determine intrinsic viscoelastic properties, which can be decoupled from the information which we get otherwise. So it requires a phase shift. And as you can see here, this is among the first devices that we have. I'll close in 30 seconds. First devices that we have which really can help measure within the cornea, instead of giving you a whole number for just the cornea alone, but moving from the center to the periphery and especially from the anterior to the depths. Even post cross-linking, till today we have never had any device which has been able to conclusively prove the biomechanical superiority which cross-linking can confer. But as you can see here, using Brillion microscopy, where the phase shift has really increased, and not only that, when you compare cases and controls, you can see that the shift is much more in the anterior cornea where the cross-linking has actually taken place and becomes progressively lower, and in the posterior cornea where actually you do not had the effect of cross-linking, it's quite similar to the control eyes. So to conclude, we have a plethora of new investigations available with us today, and early diagnosis and timely and appropriate interventions can be planned based on these wonderful investigations which we have available with us today. Thank you so much for your kind attention.
We have time for discussion. So since this is a Cornea Society of India presentation, and the idea was to have the general ophthalmologists interacting with us on any subject, covered or not covered, to do with cornea, I invite questions from the audience. Yes, sir.
This is Dr. Kannade from Pune. One question to Dr. Shweta Agarwal. She showed very nice picture of symblepharon of a small child. I would like to ask one question. What was the chemical that suffered this much lot of complications in cornea?
Well, the first picture that I showed was actually a child with potassium permanganate, and it was quite funny because the mother herself had put that drop. It was a potassium permanganate in a bottle, which the mother herself had put it in the eye of her son, and she was also clueless as to why and how she did it. But usually the most common chemical that we find in our country is chuna, that is lime, which occurs because of the plastic, the friable plastic that is available.
Chuna is by far in everybody's series here. Yeah. Yes, Subhadra. Yeah. There are not too many good ones in LVP, I understand.
I think we all know that tuna is causing a problem. So what are we doing about it? What's the point of saying tuna? Because I can tell you that there was this very nice inspirational story from Canada that Dr. Vine, about 30 years back, noticed that he was getting a lot of children with ice hockey injuries. And he worked for 10 years, and ultimately the government of Canada has made it a legal mandate that there will be no training, street play, or any ice hockey without helmets. And now it is mandatory by law to use helmets in any ice hockey, whether it's an amateur game, it's a training program or anything. So if we know that tuna packet is causing problems, are we doing anything about it? Or for next 100 years, we are going to have more and more tuna?
I invite Dr. Namrata to tell us. They've made a wonderful film from there on tuna, which was sensitizing the powers that be. And then, is there a follow-up on that? Yeah.
We've not moved any document like that, but I think that is what is required. And that is, you have to tell at least the regulatory bodies in Government of India to at least put warning on the packets, tuna packets, to say that it should be kept away from the reach of the children, and it is hazardous, or it can potentially harm. And yeah.
Dr. Subhadra, the So unfortunately, this industry is a highly unorganized industry. So you can put thousands of restrictions by government, but none of them are registered. These are small plastic pouches which are manufactured by unorganized industry. So government public awareness must be done, and we must do, but the most of the 90% of this industry is unorganized sector, which is illegal, absolutely illegally done.
Okay. Any other questions? Yeah. Shreya, come.
Very nicely you pointed out all the recent modalities for the anterior segment imaging. I just want to ask you about what is your experience about the UBM? for anterior segment imaging, UBM?
UBM has been around for quite a long time. I'm sorry I didn't include it as a newer investigative modality, but it is being increasingly used in opaque corneas to image the anterior segment, also to look at the angles especially before we go ahead to prognosticate what kind of, whether we do a transplant or a K-Pro, whether we need to do any additional surgeries prior to that in terms of handling the glaucoma as well. Any inputs?
I do regularly UBM for my K-Pro cases, especially.
K-Pro cases.
Whether I will put a Ahmed glaucoma valve or not. And that gives a clue, especially angle, as he rightly said. So it is a wonderful tool. It is very easy to do it. And our corneal surgeon is used to do it.
Yeah.
We don't take help of VR
surgeons. It's especially useful when in anterior segment OCT you cannot see the structures clearly, especially underneath the cornea, then UBM is of immense importance. If you have cornea iridic scars and you need to see whether the iris is touching the back of the cornea or not, and it is a total corneal opacity, then you can actually see the configuration of the iris. Yeah.
No, see, as far as the thickness of the scar, the depth of the scar, many tools, ASOCT, UBM, Scheimpflug, all of them give you some data. But as far as the study of the angle is concerned, as Samar mentioned, for Boston K-Pro, if you want to decide whether to put a valve or not, to study the configuration of the angle, the best modality still is the UBM.
So UBM has again revived, especially because of phakic IOLs again. Measuring STS has become quite popular among the phakic IOL surgeons. So an instrument which was partly surpassed by anterior segment OCT has again come back because of some usage which is not just limited to the cornea. High resolution ultrasound biomicroscopy, Dan Ranstein's group talk a lot about corneal epithelial thickness measurement using that, and that was a wonderful thing which we were waiting, and suddenly again ASOCT took over and said, you know what, we can do that even better than what you claimed. So yes, UBM has absolute wonderful role in multiple areas, but there's little crossover between now ASOCT and UBM. If you have the tool, wonderful. Don't have it, you still can try with the ASOCT.
Any other question? Okay. Thank you so much for being with us, and we hand over the mic to the next session. Subodha, I presume you're with the next session. Okay.